Critical thinking and coding tips for Chapter 10. Okay, our first critical thinking question. If a patient is diagnosed with a malignancy of an organ, but no specific site is documented, is it okay to use a fourth digit of 8 instead of 9? The answer: it's correct to use the fourth digit of 8 when a site is unspecified. The contiguous, overlapping, multiple site code is used only when the physician cannot determine the exact point of origin of the malignancy or if there are several sites on an organ that have the malignancy. It's not to be used if the site is unspecified. It would be incorrect and fraudulent to use the contiguous overlapping multiple site code instead of the unspecified code, even though some insurance will not pay for a hospital stay if the unspecified code is used. In these instances, it is important to query the physician to see if he or she is aware of the exact site of the cancer origin. Okay, our second critical thinking question. Should signs and symptoms be coded with the malignancy if the patient presents with signs and/or symptoms that are related to the cancer? And the answer to this question is signs and symptoms can be coded as secondary diagnoses to describe further what a patient is experiencing. However, the malignancy code should be sequenced first because it is the cause and/or etiology of the sign or symptom with which the patient presented. For example, seizures can be coded as a secondary diagnosis when the patient arrives at the hospital with seizures and is diagnosed with brain metastases, because not everyone diagnosed with brain mets has seizures. And our final critical thinking question. What are the differences between a neoplasm of uncertain behavior versus one of unspecified behavior? And our answer is uncertain behavior is a pathologic determination. Unspecified behavior indicates a lack of documentation to support a more specific cell type and therefore a more specific code assignment. A patient can have a biopsy of an organ and the cell type may show an uncertain behavior. However, if a radiology report during an inpatient stay concludes the patient has cancer, the physician may not know the cell type and may follow up as an outpatient. In this case, because the cell type has not been determined on the inpatient stay, an unspecified behavior code would have to be used. Now we'll discuss some coding tips for neoplasms. How to code neoplasms. Number 1. Begin your search by looking up the main term of the coding statement, which is the morphologic type, such as carcinoma, glioma, or a leiomyoma. This is necessary in order to learn whether the neoplasm is malignant, benign, or other that is indicated in the index. Do not begin trying to look in the neoplasm table first. The majority of the time the index will direct you to the neoplasm table. However, it's best to start with the main term for those instances you will not use the neoplasm table. If you assign a code from the neoplasm table, you still need to verify it in the tabular list just as you do with any other code from the index. And number 2. Once the index directs you to the neoplasm table, you will then continue your search by the anatomical site of the neoplasm. Now remember from medical terminology that a neoplasm means new growth. It does not mean cancer. It just means that there is a new growth. And number 3, turn to the neoplasm table in your code book. You will see 6 vertical columns shaded in different colors. You will notice that the first 3 columns are types of malignant cancers. The first column is for primary, which indicates a spreadable type of malignant cancer found at the site it originated. The second column is for secondary, which indicates the site a malignant cancer has spread to, metastatic or METS. The third column is cancer in situ, which indicates a malignant cancer that is encapsulated and does not spread. Now the next 3 columns are considered non-malignant. The fourth being benign, which are neoplasms that do not spread and are not malignant. The fifth column is for uncertain behavior, which it cannot be determined if the neoplasm is benign or malignant even after pathology examination. And the last column, the number 6, is unspecified, which in this category is used when the documentation does not give enough information to determine if the neoplasm is benign or malignant. Okay, continuing on with some coding tips. How to code a malignancy of the skin of an organ. If the documentation states malignancy neoplasm of skin of breast, the appropriate code to use is skin malignancy. Do not code the malignancy to the organ if the documentation specifically states skin of organ and not the actual glands or internal organ itself. Okay, how to code a lymphoma, which is a cancer of the lymphatic system. Lymphomas are considered primary neoplasms. They do not spread and or metastasize to secondary sites. Although the lymphoma may enter an organ such as bone or spleen, it's still classified as a lymphoma and should only be coded to the 200 to 202 series, with the fourth digit used to classify the type of lymphoma and the fifth digit used to specify the site. Now, sites that are not lymphatic can be classified to the fifth digit of 0 for extranodal and solid organ sites, or 7 for spleen. Now, it's important to review the operative reports and pathology reports for malignancy coding. Both of these can be extremely helpful in coding a specific organ site versus an unspecified site. For instance, a physician may document breast cancer only on the progress notes. However, on the operative report, he or she may state the malignancy was found on the left upper quadrant of the right breast. The same could be true of a pathology report. A physician may not have the results of a pathology report before the final progress note and discharge summary are done. If the coder reviews the pathology report and notices a significant finding, it's the duty or responsibility of the coder to query the discharging physician in order to update the progress notes and discharge summary to include those findings. Now, if the cancer is present or currently being treated, do not use a V code. Instead, code the cancer as current. Only code a history of a primary site of cancer because there is not a classification for a history of metastatic sites. If a patient currently has a metastatic cancer with a history of the primary site being removed, then code the current metastatic site with a V code for history of the primary site. Okay, code V66.7, which is encountered for palliative care, is used when a patient is in the hospital strictly for comfort measures. It's often used when a patient is on hospice care during a hospitalization. The V code should not be used as the principal diagnosis. Instead, a code for the reason for comfort care should be used, such as inoperable terminal cancer or another chronic untreatable disease and/or disorder. This V code can be used for more than just terminal cancer patients. It can be used in patients who have end-stage congestive heart failure or multi-organ failure of which there is no chance for survival, just to name a few. It's important to code neoplasms as specifically as possible. Although the MSDRG and therefore payment may not change as a result of a code being specific, these data are used extensively for research in cancer and treatments of those cancers, so therefore these data are extremely valuable to the future of medicine. And finally, we have some examples of neoplasm coding and sequencing of codes according to the OGCR. Our first one, a patient is admitted with pneumonia and has breast cancer, currently being treated with chemotherapy. Codes assigned are 486 for pneumonia and 174.9 for breast cancer. Patient is admitted with headaches. The patient is diagnosed on this admission with brain metastases from a previous lung cancer that was removed 4 years ago. The codes assigned are 198.3 for the brain mets and the V10.11 for history of lung cancer. Next one, A patient is admitted with dehydration as a result of chemotherapy. The patient is currently being treated for bone metastasis from primary colon cancer. There's no mention of surgery or other treatments for the cancer. Codes assigned are 176.51 for dehydration, 198.5 for bone mets, and 153.9 for the colon cancer. And our last one, a patient is admitted for diverticulosis with history of breast cancer status post mastectomy in 1999. The codes assigned are 562.11 for diverticulosis and V10.3 for history of breast cancer.